coming down. I'm the stand-in speaker today. It was supposed to be David Allen. I'm talking about exciting malaria work. You get me at short notice, so I apologize for that. So I'll take you out on this rather beautiful day in Edinburgh. I can normally say it's a miserable, horrible day in Edinburgh and take you to Sri Lanka, which is normally better weather, but today is really very nice. So I spent 5 years working in 2 hospitals in Anuradhapura and Polonnaru, in the big, beautiful sort of rice-growing belt of Sri Lanka. Seeing patients like this brought in with poisoning. So this works? No. Was that me or you?
That was me.
Okay. These are the wards I worked on, a bit like Little France on a busy Friday night. You'll see the 2 patients in a bed. Scrupulously clean wards, but very under-resourced. Next one. Thanks. This is a painting from the WHO in Delhi. And what it shows is the celebration of the Sri Lankan rural doctor in the 1960s. So you can see him here in the rural areas treating a small child. Possibly there's a gastric lavage going on in this one, which I'll show you later on. But even more interestingly is this. It's a little strange to see a picture of a pesticide spray on a painting celebrating rural medicine in Sri Lanka. But you'd have to remember the 1960s, that malaria had been almost wiped out in Sri Lanka as a result of widespread spraying of DDT. So it dropped from millions of cases, something like 11 cases of malaria were recognized in 1963. So at that time, pesticide use was part of the medical miracle going on in rural Sri Lanka. But what we see now is a very different picture. When I go to the hospitals, occasionally I'll see the pesticide sprayers coming through using their pyrethroids. But what I'm seeing day by day, hour by hour even, is pesticides coming in with pesticide poisoning. So it's become a very, very large cause of suicide in these areas. If we look at England and Wales, or Australia, some old data, and ask what are the 2 commonest causes of death from suicide, you see either hanging or gassing. So and gassing's actually gone down now as a result of catalytic converters on cars. You see the same picture in Australia. Poisoning, where I as a physician can have any use at all, is a relatively small proportion, about 25% of all the deaths due to poisoning. If we come to Asia, there's a very different picture. So here we see a new color, deeper dark blue appearing, and that makes up something like 60 to 75% of all deaths are actually due to pesticide poisoning. So if you look at this map, many of you I think will have heard of worldmapper.org. What this website does is kind of redraw the globe according to the incidence of the various conditions, the frequency of the various conditions. So this is the kind of classic picture, and the next one shows you what fatal self-harm looks like. So what you can see straight away is that South America and Africa have become much less important for these conditions. Self-harm is a much less common way of dealing with things there. While Europe and Asia have suddenly become much bigger. When we look at India, look at Sri Lanka, look at China, massively overrepresented in suicide, as is Korea. Okay? Predicting. So the World Health Organization said in 2006 that pesticide poisoning was the single most important means of suicide globally. And that's somewhere between 250 to 370,000. I'll have to flick my left ear. And it's not just a problem in Sri Lanka. I see it in Sri Lanka day in, day out, but I also spend time collaborating with colleagues across Asia. If we go to India, we go to the north city of Chandigarh here. You go to a pesticide shop, and what happened in the 1970s was the introduction of this pesticide called aluminium phosphide. If you go, I spend quite a bit of time wandering around pesticide shops trying to see what the local specialties are, because the pesticide, people ingest in self-harm what's used in agriculture. So if you know what's being used in agriculture, you know what's going to come into your hospital. And it's actually quite nice to see new trends coming through in a kind of safe, perverted way. So what happened in the 1970s was the introduction of aluminium phosphide. And this is a study in Chandigarh, which is the city at the center of 3 states of India. And they get many of the suicide deaths around. And you see that there are around 30 poisoning deaths, forensic postmortems per 5 years per year at this point. This is the average. And you see something happened. Massive happened in the late 1980s. And that was the introduction of aluminium phosphide into agricultural practice there. It's used as a fumigant to protect grain. So you put your grain inside a room, you throw your pesticide, your aluminium phosphide tablets in, wet them, and then get out of the room fast and seal it up and go in 2 days later. And by the time you go back in, there isn't anything living in that room. But if you ingest it in self-harm, because at the time of stress and the time of communication, that's what's close at hand, there's a very, very high case fatality. Around 60 to 70% of people who will die, they take a single capsule of aluminium phosphide. So that consequence, that massive increase in suicide, in India at that time was simply due to the new availability of a pesticide. Thanks. So self-harm and self-poisoning is a very different picture in Asia than we see here in the UK. In the last 5 years, I can remember one patient who's died in the hospital here in the Royal Infirmary from self-poisoning. Maybe 2 or 3. So the case fatality for self-poisoning is about 0.5% in the UK. And many of those deaths occur before hospital admission. So there's not much you can do about it. If you look in Asia, 12%, 13% is what I saw in this 1995 to 96 period. That's about average. It can be much higher if there's particularly toxic poisons around and being widely used. So it's a very different picture. And one of the reasons for that is the presence of antidotes. Again, if you come to paracetamol, there's about 100,000 presentations a year and 40,000 admissions, with only 150 deaths. In Sri Lanka, where pesticides are the most common form of self-harm, far fewer admissions and far more deaths. One of the reasons for that is the presence of antidotes. So we got rid of acetylcysteine in the UK, we'd suddenly have a massive wave of deaths from paracetamol poisoning. There'd be no change in the intent of people to die. People wouldn't overnight suddenly decide they really wanted to die, and therefore they tried harder, you could say. Simply we would be less successful at keeping them alive and allowing them to get through that crisis, to see the psychiatrist and get on with their lives. What we have at the moment in Sri Lanka is very poor antidotes. And that's one of the questions I looked at over the last 5. I've been working on this for 20 years and spending 5 years in Sri Lanka. The rest of the time I work in Sri Lanka from here. Next slide. So what I do now is show you a video which I think more graphically than anything I can say will tell you a little bit about what this is all about. It's a very good film if you ever want to see more about the issue of self-harm in rural Asia. But, so I'd see maybe 3 or 4 deaths some days, and on a lucky day I'd see none, but quite uncommon. The most common pesticides we saw were these 3 organophosphorus pesticides. So potash, chlorpyrifos, phenethione, and dimethoate. So these are organophosphorus, and what they do, they inhibit an enzyme called acetylcholinesterase. And then, next slide. So this is a protein that sits postsynaptically at all your cholinergic synapses in your body. And as the acetylcholine is released, binds the receptor and causes the response you want. The response is curtailed by the acetylcholine coming off and being broken down by the acetylcholinesterase. That stops you redoing things all the time. Next one again. So what happens is you inhibit the stopping. You sweat profusely, you urinate and defecate uncontrollably. Your lungs become filled with fluid, and I'll show you a video of that at the moment. Classically, very small pinpoint pupils. Your heart goes too slow. You become bradycardic. I'm unconscious. One of the problems of becoming unconscious is you then aspirate. And then respiratory failure of fasciculations. And classically, respiratory failure is what you die from. So you can kind of summarize the overall picture. You get exposed somehow, which in the patients I see as ingestion and self-harm. You get the acute cholinergic syndrome, those features we talked about, and I'll show you again in the video. And then, if you survive that and get to hospital in time, you can then possibly have neuromuscular junction failure, which will mean you'll be ventilated for 2 to 3 weeks. And being ventilated for 2 to 3 weeks is really not a good idea anywhere in the world, because it's very easy to get complications of that process, including pneumonia. But as you become unconscious in the acute clinical features, you then aspirate. You're lying on the ground, you've lost control of your airway, you're deeply unconscious, you've got some nasty stuff in your substance in your stomach which comes out into your lungs, and then you get pneumonia and ARDS. And these are all places you can die. So it's really quite a risky thing to do. So what I did for a number of years was stay in the secondary hospital up here. So think what happens in the village, someone takes pesticide. They do it often in front of people. It's about communication. It's about telling people what's happened to them and asking for someone to deal with that problem. They get put into a 3-wheeler, rushed in a 3-wheeler to the primary hospital, where they're very rapidly triaged. And if they look sick at all, they get moved rapidly onto the secondary hospital. People don't really want deaths in these small rural hospitals run by 1 or 2 doctors. Anyone who's sick gets pushed onto the secondary hospital where the video was done. So if you could just click that, it should work. see this froth coming out of his mouth? His lungs are producing vast amount of fluid, and his lungs are basically filling up. You see their conscious levels very low. In a moment, so this is, you can see this is pouring out of his mouth. And this is this cholinergic overstimulation in the lungs, causing the lungs to fill with protein and fluid, and the lung doesn't get rid of it. So that's pouring out of his mouth, stopping his lungs working to oxygen in his body. He's also about to stop breathing sometime later on. So those are peripheral effects. You also get a central effect on the respiratory center of the brain, which tells your brain to stop sending signals to your diaphragm to work. That signal stops working, you stop breathing and die if you're not in the hospital. So one of the key things about pesticide poisoning is how fast do these features come on. If they come on slowly, you've got time to get to hospital. If they come on very fast, you die outside the hospital. So as a clinician, being a very simple clinician, we first went and said, can we try and take care of patients better when they get to hospital? So here, there's a patient who's come in with aspiration. So he's been given a gastric lavage, and he's managed to aspirate both sides. Which again, they've lost consciousness and they've lost control of the airway. And one of the points is there's very few antidotes. So therefore, the clinical care is about getting the poisons out of the body. And if you can't get them out, if you can't treat them, you need to get them out, and that involves gastric lavage or forced emesis. So there's a big culture to do that. But unfortunately, you get complications like this. Next slide. Let's see if that one decided to work, or if that's also deciding not to work. Fine. Really? Fine. That's a video nasty. They don't want everyone to see a video nasty about gastric lavage. This simply tells you don't go to hospital with a large person in Sri Lanka, because they'll all be asked by the ward staff to pin you down. A tube will go down, water will go in until it starts coming out the top, which tells you you've got enough water in the stomach. It's a really fairly dangerous thing to do, and was not very different from what we were doing here 30 years ago. But the poisons in the UK are so less toxic, the culture has moved away from doing lavage here now, about looking after the patient more carefully. In Asia, where the poisons are so toxic, there's a desperation to get them out. And it's probably counterproductive. It probably kills more patients than actually benefits, and actually does kill. What else the Holster's doing with our group is set up a model of aspiration, a pig model. So this is a pig lung early, and this is pig lungs after they've aspirated. And you see this area consolidation here. So you can see it here. And what she's doing is looking at those inflammatory markers, trying to understand what the process is and how we can intervene. Next slide. But what is really very interesting here, this is the lung with an aspirate down, pesticide and stomach contents. You can see that is a pretty bad looking lung. But of real interest as well is, even if you don't aspirate, and this lung has been protected, and this has only seen organophosphate through the blood, what's happened here is that this is also really badly damaged. And unfortunately, I don't have a slide at the moment of a normal looking lung, but I can assure you my lungs do not look like that, having had a life of immense purity for many years. So not only do you have a problem of lung injury from aspirating, because a big enough problem, there's a very good chance of killing you. You also get some level of lung injury just by the lungs being exposed to pesticide in the soul and probably in the blood. Okay? So that is a very important aspect of what causes the patients who survive the initial crisis, who get to hospital, who get intubated, and then about 50% will die in intensive care. That's probably part of the reason. So we did a clinical trial to say, can we give activated charcoal? Charcoal goes in the stomach, binds the poison, and prevents it being absorbed. And if you give it later, it will actually pull poison out of the body. So you either got it orally, you see the son here holding the vomit bucket, because it's quite easy to vomit after this. Or if you're unconscious, in an intubated patient who's been intubated and ventilated, you're getting the charcoal down by the tube. And then about 3,500 patients in our study who've got charcoal, there were many, many deaths, but not a single one had charcoal in their lungs. So you can give it very safely, and very different to the gastric lavage situation. But if you look at the outcome, and this plot tells you the line here is of no effect, and if the boxes are on this side, it says it favours the activated charcoal, this is the multiple dose arm, versus no activated charcoal. You can see they're pretty much on this line. The confidence intervals always touch it, and the boxes are actually often very much on it. So there's a possibility of a very small benefit from activated charcoal. One thing that is good about this is it stops people doing forced emesis and gastric lavage. if you can encourage doctors to look busy, to do things, and it's appreciated by relatives. Relatives hate physicians who stand on the bottom of the bed going, let's wait 4 hours, see what happens. If you can give charcoal, which we've proven is safe, you can actually make a difference to these patients. So this was I once came to a Wellcome Trust presentation with the funders. I was trying to tell them how well I was doing, and I stopped it there. It was about 3 weeks into this fairly nasty period of my life. And I managed to bring it back, so it looked like we were recruiting ahead of the game. This was our line, and we were trying to get the study done quickly, but then something horrible happened. And this was a Monday morning radio program. This was on the radio, as I was told later on. I was quite glad the black chemical was found in the stomach, because if it had been in the lungs, that might have been a little reason for complaint, but having a mysterious black chemical in the stomach and a gas in the activated charcoal trial, I thought was reasonably reasonable. So I hoped it would go away with time, but then unfortunately the next day, this came out in the newspaper. A beautiful script. Actually, that's the same day. I mean, seeing the script's quite beautiful, but this is the word they said. One of the nice things about working in Coronegla, I was the only white man in the whole city of 40,000 people. So every time I walked out of the hospital, they knew damn well who I was. I was affectionately known as the butcher of Coronegla at that point. But you can, instead of having to fight your way through crowds, the crowds would just fade away in front of you as I walked out. It felt like kind of Jesus and Messiah, but kind of wrong way. It was a horrible political issue that my Sri Lankan boss was disliked by the surgeon in the hospital, who then went to the newspapers after a patient I treated died and said, that doctor killed this patient, please put it on all newspapers, which they then went away and did. So makes the sun seem the height of reasonable, responsible journalism. And then, interesting period of my life, but after 3 months of guidance, therapy, drinking, we managed to get the study going again. But there's a long story there. So come back to these three poisons, the next one. So they were phenomenally important. When I first went there in 95, 96, and I went to the intensive care unit, 42% of all beds were occupied by people like this, being ventilated for long periods of time. 50% of those patients die. So you put them in intensive care, you block other patients in, and they still die. It's really kind of depressing time. It's very hard to keep these patients alive. And you can see that snakebite was the second most important, and everything else couldn't get in because there were never any beds. And even this person can't get in because there's no bed. She's on the open ward at 37 degrees centigrade. So we know OPs kill about 200,000 people a year, and there's probably 3,000 to 6,000 people at the moment being ventilated across the world for this one problem. So if you go to intensive care units, you'll find these problems. We were very lucky because there are 3 particular OPs we saw happen to be very different. So phenethion is a slow-acting fat-soluble OP, so it will go to the fats and then come out over time. So patients were never sick. We never had patients dying on admission. This chart shows the time to death. So that's 1 week, 2 weeks, 3 weeks post-exposure. And you can see, phenethion, they didn't die in admission. They were never very sick even. They got sick later, and they had sudden respiratory arrest when their neuromuscular junction failed later on, and I'll show you that later on. Chlorpyrifos were often sick on admission. They'd often die as they got there, or they'd aspirate. And this great smear of deaths here is because of the pulmonary complications of that early cholinergic poisoning. So they came in, they were quite sick originally, and they may have survived that, but they might die from complications. Well, dimethylates were untreatable. They came in and actually died from cardiac disease. They had distributive shock. Their heart beat, but their blood vessels were too dilated and they finally just died. Normally between 24 and 48 hours here. And it was very, very difficult to treat. One of the interesting points here is that we base all our regulatory decisions about which OPs were allowed in the world based on their rat oral LD50. So you take a rat, you gavage, give it orally the pesticide, and count how many died with different doses. And then you come up with a dose. Most of this was done in the 1960s and 1970s. It's not really done anymore. But it's a crude but fairly accurate way of working how toxic these things are to rats. So if I'm a rat and I'm going to try to scare my mother, which part of self-harm is about, it's about communicating distress, I'm going to choose a nice safe one. So if I'm a rat, I'm going to choose dimethylate, because the LD50 for rats is quite low, 250 milligrams per kilogram. I'm not going to choose chlorpyrifos, because that rat LD50 is about half or 40% of that, and that's about 100 milligrams per kilogram. But in humans, it's the other way around. Here, if I want to frighten my mother, I'm going nowhere near dimethylate, because there's a good chance if I take enough of that, I'm going to kill myself. while here, I take chlorpyrifos is much safer. One of the reasons for that is dimethoate's untreatable. It may be less toxic, but if I can't treat it, it doesn't really matter the pure toxicity. Chlorpyrifos is really quite toxic, but I can treat it better. So therefore, the problem about using animal LD50 studies for regulatory approval, it doesn't take into account the treatability of these things. And so we've actually got these the wrong way around, according to actually really toxic they are to humans. Dimethoate was not thought to be that toxic, but it's 3 times more toxic than this one. Okay. So these are the antidotes. There were 2 papers in the 1950s. Atropine, New England Journal of Medicine, hasn't really changed much since, until our work started. Praladoxine, paper in about 58 from New York. That was discovered. Being used by a guy called Namba, a Japanese guy who moved to the States, and he showed very clearly it worked very well for highly potent occupational exposure. And that was what our treatment was based on. Next slide. But mortality rates were still 20%. So though we had these antidotes and we'd used them for 40, 50 years, we weren't getting very good benefits. So a group of us sat together and came up with a protocol which we used on our patients in Sri Lanka and routinely used it for patient after patient after patient after patient. And there's probably 20,000 patients now. We published it quite early, and it's been accessed over 33,000 times. There are not many academics in clinical toxicology, so my papers don't get cited very often because no one's writing papers. If I was a cardiologist, that would be famous. But open access proves that people are using your work in a way. There are probably, I can't locate, maybe I can with this, where those downloads are coming from. But I think you find a lot of them across Asia, of doctors going there, finding the protocol and downloading it and using it. Next slide. So what we said was, the best way to treat these patients, we're going to get rid of that frothing. Okay, we've got to clear those lungs up, get rid of the fluid, get oxygen into them. It's the fundamental thing we need to do, and atropine is the drug to do it. It's a muscarinic antagonist. It antagonizes the excess amount of acetylcholine. Okay? So you don't know how much a patient needs, because they've taken different doses of different pesticides at different times. They just look the same. I've got no idea how much to give. So the textbook said give 2 milligrams every 15 minutes, and keep going. But some patients need 100 milligrams or more. And some of those protocols would take 24 hours to get a patient resuscitated. And nowhere would you recommend taking that long. So what we said was, give 2 milligrams, if that doesn't work, give 4. That doesn't work, give 8. That doesn't work, give 16, until you start seeing a response. So here's this kind of a model patient. So his lungs are full of fluid. Given 2, 4, 8, some accumulation there of 14 milligrams. Nothing happened. 16, you then start seeing a response. And then you don't give double anymore, you just give enough. You're trying to dose titrate it to the particular patient. And we thought this was likely to be beneficial, because we showed you could give enough atropine to your average patient in about 20 minutes. And I have an attention span which is probably less than 20 minutes. As a doctor standing with a patient, that's the kind of time frame I want to be working in. Thanks. So there was interest. The Bangladeshis went away and checked it and did a clinical study. This is an amazing man called Muhammad Abdul Faiz. I think he's now in Dhaka, but he was in Chittagong at this time, with a group. So I know Ariful Basha. There's a group of very impressive Bangladeshi clinicians. So what they did was they compared their conventional bolus protocol with our titrated doubling protocol. And this was just giving boluses. This was a titrate up as fast as you can, and then give an infusion. The next slide. And what you see, the most important thing is time to atropinization. It's basically successful resuscitation. Has reduced from 2.5 hours to 24 minutes for a population of around 80 patients. And I think that's really good, because it means you get doctors who focus on the patient. 2.5 hours, I've got 25 other patients to see. I can't spend 2.5 hours with this patient. Doesn't matter how ill they are. I've got way too many other patients to see. So I think if you can shorten that down, and you're looking at a result every 5 minutes, you can keep the doctor's attention on the patient. And I think is likely to be beneficial. And what they show was the mortality fell from 22% to 8%. I think that is less important than that difference, but I think it's likely to be associated with it. And so they went away and proved this is likely to be beneficial to patients. How do you?
They've got way less atropine toxicity despite giving a much higher dose.
Because you're titrating it to the patient's clinical features. The bolus, you're deciding how much to give. They're giving the same bolus dose whenever they feel they need it. I might just give 1 milligram to a patient who's had lots already. So it's just about getting the right dose. And also they get an infusion. So you get where you want to be, and then you get a nice gradual infusion. While otherwise they're giving boluses. They're going up and down like this, if you think of their pharmacokinetics. While otherwise you're trying to get up as fast as you can, and then keep it there and bring it down slowly over time. I think it's consistent. Next one. Pralidoxine, the only piece of pharmacology in the talk. Acetylcholinesterase is the enzyme that sits postsynaptically cleaving your acetylcholine. Your organophosphate comes along, binds to it, phosphorylates it. So you've got and this is called dimethyl, because there's two methyl groups here. 50% of them are diethyl. And so this is a dimethyl phosphorylated OP. It doesn't matter about acetylcholinesterase. It doesn't matter which OP's done it. It's just either going to dump two methyls or two ethyls on there. That is inhibited and can't do anything. You start frothing at the mouth. You'll slowly reactivate that. But that takes seconds. That takes hours. So basically you're inhibited. But you give pralidoxine, you can speed up number 2. Okay? If you give enough pralidoxine and the dose of OP is not too high, you can make 1 equal 2. Okay? And then you can get a patient who's fully resuscitated. The longer you take to give the pralidoxine, the more chance of this reaction 3 happening. And if you allow number 3 to happen, you lose an alkyl group, and then you can no longer reactivate your pralidoxine. It's too late to use pralidoxine. The WHO in 2000 came out with the recommendations. Resuscitate, atropine, and oximes. First 2, no doubt. We've now managed to improve how you give atropine, but with no doubt giving it. Oximes, it's not clear. Most Asian doctors weren't sure it worked. But the WHO said, in response to these discussions about lack of data, they said no clinical trials are warranted to test the effectiveness of oximes. We know they work, give it. So, being obnoxious, we know that's probably not right. Remember I said you either get diethyl OPs or dimethyl. And therefore the inhibited acetylcholinesterase is either inhibited by a diethyl group or a dimethyl group. If you take a patient who's come in, this patient's quite sick. We all should be at 600. Unless you cover with sweat the small pupils and you're slobbering at the mouth, you're probably at 600. If you take OP, you're down to this, you're quite sick. For a dimethyl, you give pralidoxine, beautiful reactivation. Okay? So it looks like it works with diethyl, but there's nothing for dimethyl, and that's consistent. Nothing or very small, significantly less than this. So that suggests that for 50% of the patients out there, you're not going to get a benefit from pralidoxine. Therefore, pralidoxine better be safe. Because if you're giving a drug to 50% of patients where there's no benefit, the risk-benefit ratio is going to be skewed one way if there's any risk at all. And you better make sure it works in the other lot, the diethyls, because if it isn't working in them, it's really not a very successful drug. So back to the same charts. Remember, this side means good, this side means bad. And as a general theme, everything's on the bad side. And this is remarkable. I was really quite confident this was going to work. Confident, I was hopeful it was going to be a great treatment. It's quite expensive, but if it worked, it got patients out of intensive care unit, it could reduce the amount of time they were ventilated, it could save lives. There was just so many win-win-wins. And unfortunately, we couldn't find it working for anything. We proved we gave the right dose, we measured it in every patient. We proved we got acetylcholinesterase reactivation, we measured that in every patient. And we got no clinical benefit. So we had a good surrogate marker productivity. But this is death, and fundamentally, who cares about surrogate markers if you could measure death as well? And diethyl is where we know there is good reactivation in the blood. Not many deaths, fewer deaths in this group, but skewed towards death. The trial stopped early because there's another trial that came out which had the opposite answer. I would argue probably not as good a trial, and we ended up stopping the trial. What we can say from this study was it does not look as if pralidoxine is highly effective. That's as strong as we could say. Worries me that it's killing patients. And one of the differences between the two studies was that in their study, 75% of patients were intubated at baseline in an intensive care. It was a private hospital, and you cannot get that across Asia. We had 17% of patients intubated at baseline, which is about reasonable. Okay, it would be nicer to have got more, but it's just not the facilities. So if you've got a drug which only works in intensive care, it's not great for district hospitals across Asia seeing the great majority of these patients. So next slide.
Well, sorry, I'm wondering what the conditions were in the original research.
That was occupational poisoning, and it was very highly potent OPs. So a small dose of these OPs gave you quite marked signs, but they're occupational, so the dose is much, much lower. And so you give pralidoxine, and then you did get reactivation, and it was just 5 or 6 patients in a case series. It looked pretty convincing. What we're dealing with here is much less toxic pesticides, which in a much bigger dose, because they just drink a whole bottle. And in that condition, which is where most of the deaths are now occurring in Asia, you're getting a very different scenario. This one. Come back to these dimethylate deaths. Why we weren't getting any benefit from pralidoxine at all, particularly in these patients, and why were they dying? I couldn't do really detailed mechanistic studies in unconscious Sri Lankan patients. There's just so many ethical issues there. So I came back to the UK. What I did is I set up a pig model up at Easter Bush. So we take pigs, they're anaesthetized, they're cared for by veterinary anaesthetists, and we then poison them and try to treat them in the way which we would treat this patient, and I'm trying to take the lessons I learned from this back into Sri Lanka. Okay, next slide. And this is 2.5 years' work of incredibly long studies. So these are pig studies that last 12 hours. When I drink dimethoate, I'm not drinking the pure active ingredient, the pure campana, the pure compound plus surfactant plus solvents. Because I'm a farmer, I'm not putting my hand in a bag and spreading the neat stuff on the ground. I'm mixing it with water. To do that, I need solvents and surfactants. So that's what dimethoate EC is. Dimethoate AI is the pure thing I buy from Sigma. It's got nothing to do with agricultural farmers, the people who are self-harming in Asia. A placebo is saline. And if I give these pigs saline, they do pretty well, using lactate as a marker of badness. High lactate means you're sick. If I give dimethoate, you're really very sick, and it's pretty hard to keep you alive. We had a power cut once. We managed to blow all the fuses in the lab, and the pig was dead in 10 minutes. So they're only alive, that was about 2.5 hours. They're only alive for 12 hours because of serious intensive care, exactly what we give to patients in Sri Lanka. If we give the pure dimethoate exactly the same dose, and I've measured it in the blood, and I can show you the doses are the same, I don't kill the patient so much. So it's not purely about the dimethoate. And what we were able to show, it's a combination of the dimethoate and the solvent. Each by themselves are not very toxic. But the two together, you get a very toxic one. So one reason our pralidoxime is not working is because we're not actually dealing with what the poison is. We talk about OP poisoning, but it's never OP. It's always OP+. And that's a case of any single case of pesticide poisoning ever. There's always been solvent there, always been surfactant, particularly when you ingest from the neat bottle. Okay? So what we did is we went to the company in Denmark and said, your EC40 is killing lots of people. Do you have a safer formulation with a different solvent and a different surfactant? And they gave us this one. It's actually got the same amount of dimethoate in, a different solvent, and you can see these pigs were much less sick. So in theory, we could change the dose response, or the lethality of these, by changing the formulation. The problem with that is it says on the bottle, do not drink. And so the industry says, well, why should we be changing the formulation of our bottles because some idiot drinks it? And the point you have to come back to is, which your customers. They're buying it from you. They're using your product. They're killing themselves with your product. You have to take it seriously. But it's a difficult long-term discussion. But what it will mean is you can potentially save thousands of deaths across the world just by reformulating the pesticides to make them safer for human use. But you should say on the label, do not drink. But if you do, it's probably a bit less toxic than that one next door. One of the things I try and do is make self-harm a family-friendly, safe activity. Because self-harm has a kind of role or a purpose for many people. If we could actually make it a less lethal, less dangerous way of doing it, I, as a simple clinician, think that's quite a good idea. Psychiatrists are generally appalled by the concept. So we talked about those phenthyon poison patients who died from sudden respiratory arrest later on. So here's a patient. I hope this works. If not, I'm going to just quickly close down to the next one. If you are querying this, is incompetence. Okay, so this guy, he's been in hospital a few days. We're asking him to lift his head off the pillow. And he's hopefully chatty, he talks all the time. We see he's got complete loss of power in his neck. That's one of the strongest muscles in your body. You should. You see he's talking, he's chatting. I don't know why he is. I've been lying in bed too long, my neck's gone weak. We then ask him, are you breathing okay? So he's asked to use a minute respirometer. This looks at how well he can move his chest wall. And that dial tells you how well it's going. It goes half and then another one. That is good breathing. That is normal. I probably do about the same. But we know he's lost the power in his neck, so we're very nervous about this patient. His neuromuscular junction is stopping working. And something soon is going to go wrong with his diaphragm and his intercostal muscles. So we then, this is how I find him the next morning. He is so weak, his son has to hold his head up. He's using all his accessory muscles of ventilation. And he was about to have a respiratory arrest. But luckily, the ward round had already passed him and was already on to the next patient because they weren't that interested in this guy. It was a shame. So we intubate him straight away, give him some diazepam, and the ventilator is not yet attached. You see the sort of absence of a ventilator here, but it's on its way. He's still in the last remnants of breathing, and your respiratory rests in probably an hour, but he's already on a ventilator by that point. He spends 2 weeks being ventilated, and then he's perfectly okay. Fine. So let's go back to the pig model. We're going to have a model of this. Expose the nerve in the arm, stimulate the nerve, and transduce the power going through the claw. So if you do this, or if you stimulate the nerve, I did any of you, your hands would flick. And you can measure the force of that. It's kind of classical neurophysiology. So you get 4 deflections down, showing the strength of the flick that results from nerve stimulation. And you can see that 12 hours of saline placebo and anesthesia, you get a reduction. No, this isn't probably not as great as that. Don't be anesthetized. Terrible thing. If you give dimethylate, you get a complete fall off of the neuromuscular junction. By 12 hours, you've lost all power of your neuromuscular junction. And that's what we see in the patients. So this is the first model which recreated what we see in patients. If you give the dimethylate alone, which is what everyone's researched for 50 years, you don't get the effect. Again, it's not the neuromuscular junction alone. It's not the OP alone. It's the OP plus the solvent. And I'm working with Richard Ribchester and Costa Dissanayake in CIP, and they're doing beautiful work showing actually, not only is it the combination, it's the metabolites of both. It's not even the solvent, it's the metabolite of the solvent together. And they seem to work at 3 or 4 different areas of the neuromuscular junction together to cause the effect. What we hypothesize is if you could prevent one side, if you could prevent the OP effect, you may be able to prevent it. So you can interrupt. So look at the receptors of the neuromuscular junction. You've got nicotinic receptors before and afters. And these are overstimulated by the vast amount of acetylcholine floating around. Okay? What we presume would happen, overstimulation causes downregulation, and then takes you a week or 2 weeks to repair the neuromuscular junction again and get it working again. So if you can put a drug, like a neuroblocking agent using anesthesia here, to sit on those receptors and protect them from the overstimulation by the acetylcholine, they won't work for a while. But you can treat the patient in the meantime with ventilation, and then as the OP comes out of the system, you can remove those drugs and then your muscular junction should start working again because it's not being damaged. It's just being protected in a non-functioning way. Okay, next slide. So this is a study. We kind of this is proof of principle. So you give the dimethylate EC, you lose the neuromuscular junction, gone by 5 hours in this case. We got a new batch from Chemino, which seems to have a particularly variable but lethal effect on the neuromuscular junction. So what we'll do is give rocuronium, a blocker which affects pre- and postsynaptically and sits there, protects them, and we give it and we collapse the neuromuscular junction function before we give dimethylate. And we get it down to actually 99% inhibited. And we can show this every minute by measuring trainer 4. Okay? So we keep an infusion of rocuronium going, and so this one here has got rocuronium going in, and we've actually lost the T1. We give sugamidex, which pulls off the rocuronium, and 2 minutes later, you get normal function. And this is 8 hours post-ingestion, post-exposure. So proof of principle, you can block the neuromuscular junction on the nicotinic receptors, and you can prevent damage which would have occurred if it hadn't been there. Okay, this is a pre-exposure. We've tried 2 hours post-exposure and got some benefit. Not as good, but some. But dimethylate is not a good model in the pig of what's happening in the human. So we have to move to human studies. So we're going through ethics and moment in Sri Lanka to do that with our anesthetic colleagues in Peradeniya. With luck, we'll be able to do 3 patients initially and try and see if we can just block off the neuromuscular junction as they come in with the acute cholinergic syndrome and they need intubation, so they're already going to the ventilator. Can we give a neuromuscular blocker, put it in, measure the acetylcholinesterase or the butyrylcholinesterase in the blood? As it starts going up again, that will tell you the OP's out of the system, then you can pull off the rocuronium, and in theory, next slide, this woman will stand up out of bed, take a tube off and walk out. That would be pretty exciting when it happens. I mean, God knows what's going to happen. But if we can just make a difference, if we can make it 2 or 3 days of iatrogenically induced ventilatory failure versus 3 weeks of ventilatory failure due to damage, it would make a huge difference. People die because they're being ventilated, because they're paralyzed. You can prevent the paralysis, get people up and around and moving, even aspiration becomes less dangerous.
You mentioned that it was quite a long journey though, sometimes to get to the hospital.
Well, not that long. In Sri Lanka, in Nepal, it can take days. In Sri Lanka, the median time to arrival at a secondary hospital is 3 hours. So the median time to arrival at a primary hospital is about 1 hour. So when I treat at 2 hours, I'm thinking about something I could give at a secondary hospital, a primary hospital, if I'm really lucky, at a secondary hospital. Next one. So that's me working in a secondary hospital. There's a bunch of other stuff we're doing. We're trying to take other treatments from pigs into humans. Like a trial in Bangladesh, I'm going through ethics in Bangladesh for looking at salbutamol. Because salbutamol should increase the removal of fluid from the lung. When you give atropine, you turn off the tap, but you don't empty the lungs. So I can turn off the tap and empty the lung by giving salbutamol and removing the fluid. I can make resuscitation even quicker. I get it to 10 minutes rather than 24, that'd be a dream. But again, that's always being a simple physician working in a secondary hospital, and clearly what I should be doing is here. If you think about the big public health picture. So this is a man. Have you ever heard of him? Absolutely brilliant man. Awful person, apparently, but a very, very impressive man. So he was the head of this insurance. It was a car insurance funded agency which tried to do research. If we look at what was happening in the 1950s and 60s, car deaths on the road in the States were going up exponentially. Everybody wanted a car, everybody drove it badly. And the basic philosophy was, if you drive a car, don't have an accident. If you have an accident and you die, well, I'm sorry, don't have an accident. And there's a wonderful photograph there of a freeway with this beautiful lamppost, pristine, absolutely pristine, obviously just put up, solid steel. And there's a car at the bottom of it cut in half. So the car had hit the lamppost, instead of the lamppost falling over elegantly, it stayed up nice and solid, and the car had cut in half. All the bodies have gone off by this point. But the philosophy was, don't crash. If you're going to crash, you're going to die. He was the one who said, no, that's a bit silly. Let's think about harm minimization. Let's accept crashes will happen, even if it's because of that 17-year-old drinking boy who drives down the corner and drives you off the road. Let's try and make crashes safe. So what he did, he invented, created, or he initiated the process of making collapsible steering columns and making bonnets collapse. Because in the past there was solid American steel, and if they hit you, they just chopped your head off. So if you're a little old granny sitting over the steering wheel, you've got the paramedics come and take the head off in the body. If you're like me, you've got transected across the here, and the paramedics have the top up half of my chest and the bottom half of my chest. Or they'd have to pull you off, pull you off the steering wheel column. So he changed that, and he made these little areas where you sit now safe. The cages. He did monkey studies and stuff. So they put monkeys in and crashed monkeys and worked out how to make sure monkeys didn't get crushed. So you could argue ethically there were some interesting points there. But he caused this. Exponential rise, implementation of his changes, a gradual decrease in deaths on American roads. Even though there's been an exponential increase in numbers of cars on the roads. And they do drive very close to each other. So his approach to harm minimization transformed cars. He's also done some beautiful stuff. I don't have time to go. I'll late time with it. Yeah, I'll tell you a big story. There's a wonderful story about how to stop deaths in Bengal tigers, and another paper about how to stop deaths from nuclear energy. And they go through 10 different stages of where you work. The most effective, get rid of the Bengal tiger, right the way down to give everybody in the town a sword and a shield to fight off the Bengal tiger when it gets out. And he kind of thinks all the way through how you could reduce injury deaths. And it's really beautiful work. So you could divide into three things. You engineer controls. You work at a really top, high level. So in pesticides, you get rid of pesticides. You change agriculture, or you ban the most toxic ones. The difference here is administrative control. So that's kind of a passive prevention. Active prevention, people have to follow rules. So in Sri Lanka, you put your pesticides away. But that's very active. And then you've got what I do, the kind of subcortical, foolish stuff, which is about working right at the bottom end, basically giving the sword and the shield to patients, trying to keep them alive after the events happened. Next one. So, let's go back out to here. And the studies we're doing at the moment. We're looking at administrative controls. And the reason we're doing this is because industry believes if you put your pesticides away in a box every night, no one can self-harm, and it'll solve the problem of self-harm and suicide across Asia. But I don't put my clothes away in my cupboard every night. The likelihood of me putting my pesticide box away every night in that box and locking it up is pretty low. And also people attack these with crowbars. So industry had done a small study and had gone out across the world saying, this is the answer to suicide in Asia. Get these boxes, containers into everybody's houses, we'll never have any more. And they did a really dodgy, small study to prove that. So we thought we need to do a big, high-quality study. So I worked with this guy called Flemming Conradsen from Copenhagen. And he's worked here since '93. In this area, the Mahabali area of Sri Lanka. And we ended up doing a big study there. So next slide. This remarkable woman is called Melissa Pearson. She's a social worker who therefore knows how to deal with medics, she tells me. So she runs this study. We have this big group working in Sri Lanka. And we've set up a cluster randomized control trial, 160 villages, divided to get these boxes or no boxes, the one I showed you. The nice thing about the ones we've designed is, with the help of the local farmers, is they go in the ground away from the house. Previously, they've always been in the house. It's always been a bit of a big red flag. Skull and crossbones, here's the good stuff, filling down, come and get me. The nice thing about these boxes, they're out of the house, out of view, and mostly they're drunk men who take the pesticide. So by the time they get there, they're hopefully asleep. They can't get the lid off, and they can't see the key into the padlock. So then they take their frustration out with a crowbar trying to beat the door, beat the thing open, but it's not that easy to open. So if it's going to work, this is probably about as good a way as possible. Next one. So what we do, we use Google Earth to identify all the houses. We plot them, and then this team go out and find who lives in the house and get a record. And through that, we've been to 54,000 households, and we've recruited 223,000 people to a randomized control trial. Next slide. When you're randomized, if you're then randomized to a village with a box, you then meet in the local temple, you get given a box, each one of them is numbered, they go in the ground, your pesticides go in, there's a lid for security and a lid for weather. It costs about $25 each. If it's going to work, like bed nets, it should come down in price as it's done at wider cost. So this is the area. These are all the houses. So you can see the control houses are in red. You see how they group together. One of the complex things was drawing around communities, because if you followed the government communities, they're often either side of a road. So you'd have one person on one side of the road with a box and one side of the other road without a box. And we try to make sure that didn't happen. So there's some really very complex motorbiking, mapping, drawing, talking, trying to find natural communities throughout this whole area. And these are the numbers, 53,500 households. Next slide. We have interesting data from all these households. This, about 25% of households report alcohol as being a problem in their household. About 60% use alcohol, and 25% call it a problem in their household. We have all the previous evidence of fatal self-harm, non-fatal, and fatal self-harm in all these villages. So we can follow things out over time, doing prospective and also retrospective studies. What we do is we work in 13 peripheral hospitals, and for self-poisoning in particular, everybody goes to hospital. I've seen patients where they're saying, I didn't take anything. And the family's going, I'm pretty sure they did. And so you have patients in hospital denying that they're in hospital, because that's where everybody takes them, unless they die outside. So we follow all the deaths and all the cases. This is the secondary hospital. These are the 13 peripheral hospitals. So some patients are recognized only here, some are transferred, and some are found on death records. And all the deaths tend to occur in the secondary hospital. They don't occur in the primary hospital. And we're able to match 100% of cases back to a household at baseline, which then says we know which arm they're in. Because we're blinded, we don't ask them, do you have a box in your house? We simply say, where do you live? And then we can match that to baseline. So that's a fascinating study that's going on at the moment and allows us to do many other things. But really, that's administrative control. I fundamentally don't believe it's the best way to go. It might be part of a holistic solution, but it's not the solution at all. This is more like the solution. I want self-harm to be family-friendly activity. I want every house to have a box of pesticides with a chitin inhibitor. Now, I had this beautiful guy I really liked, 65-year-old man, complete alcoholic. His wife hated him. All three of his children hated him. His crops had failed for the last 3 years every single time. So he was pretty down. He went to the pesticide shop and said, give me your best insecticide. Put his life savings, $4 down, and was given a bottle of chlorpyrrazole. Walked home, stood in front of his family, took the lid off, drank it, said, I'm dying because of you, I hate you all. It's all your fault. And he spent 3 days going, when am I going to die? He said, well, you're taking a chitin inhibitor. There's really very little way of dying from a chitin inhibitor unless you aspirate. So if he'd been completely blind drunk when he took it, there would have been some chance of him dying from aspiration as a complication, but not due to the pesticide itself. So some of the modern pesticides are extremely safe. So this is the map of suicide in Sri Lanka, so a chart of suicide up to the 1960s. So what happened in the 60s? Why has suicide got out of the roof?
Pesticides introduced.
And what's that process called?
Agricultural green revolution.
Right, green revolution occurred. Suddenly pesticides were in everybody's house. The FAO, agricultural ministries, everybody was saying, we need high yield types of rice, etc., which need fertilizers and need pesticides, and you need them in your house to use it. So suddenly, suicide took off. What happened here? Bajranayaka came to power. She made a social democratic republic, no more imports. So I had friends smuggling stuff into Sri Lanka at that time. But basically, you couldn't get pesticides. And then Jayawardenepal came into power, back it goes. Open economy. What happened here?
Civil war.
No.
Safe pesticide.
Yes. And how would you do that?
The new ones with
Invert that.
okay, without the lethal.
You get rid of the toxic ones.
Get rid of okay.
So You've always had lots and lots of different pesticides, but you have a few which were particularly poisonous. And some were so poisonous and so commonly used, they became the abbreviation for self-harm. I did a Tamaron today. Tamaron's the name of metamidofos. That was in the 90s. In the 80s, I did a folidol. He did the folidol, you did the folidol, we do folidol. And that is a methylparathione. So those were banned, and that's because of this man. So as I said, I probably saved 4 or 5 lives as a physician. Maybe if I was feeling generous and a bit drunk, I might boast about 10. This guy saved 17,000 lives in 10 years by banning these pesticides. And this fall is the biggest ever fall and fastest fall in suicide anywhere in the world, purely because of banning 3 pesticides. The rate of self-poisoning with pesticides continued to increase. So from a mental health perspective, it's not a great success. But my argument is, well, they're alive to see a psychiatrist. If you're not alive to see a psychiatrist, there's no point in having a psychiatrist. So there's a little bit of conflict there occasionally. But the other thing was hanging. People say, well, if you can't die from lethal pesticides, you start swinging the chitin inhibitors and no one's dying, or they're all going to run off and jump off a bridge. Well, A, it takes a long time to find those bridges, because it's not like living in Hong Kong, where, frankly, everything's a bridge or a tall building. In rural Asia, it's quite hard to die. You've got to wait for the train to come or find a bridge, and normally you've changed your mind by that point. So actually, this is overall, this is not just pesticide poisoning, this is total suicide. So though there was some switching, a few people who really did want to die, who didn't get the mental health support they needed, or the community support, did switch to hanging. But hanging is down here. It's really down here. So there's been a small increase in hanging, but there's no way you compensated for the massive reduction in suicide. And the next one. The key question, though, the agriculture minister says, you can't ban my pesticides. I need them. I need that pesticide for my agricultural yield. If you stop banning those pesticides, the country will starve. So if you've got to look at the data, and these are three crops, we looked at multiple crops in 4 different South Asian countries with a very similar background. And said, was there any difference in Sri Lanka compared to other countries from 1995 when that major ban happened, resulting in the 50% reduction in suicide? There is no change at all in crop outputs or crop inputs. So you're able to go back and say, actually, you can change the most lethal ones, move to safer ones without having major effects. Because if it cost more to use these new pesticides, you would have seen a reduction in crop yield. Okay? So what the real answer is to try and combine the health costs and the agricultural costs. You need to combine them both, because if you don't do, the agriculture ministry won't listen to you, and they're probably the most important ministry to work with. So what I want to do, it probably won't be Sri Lanka. Sri Lanka's done so many bans, they're actually ahead of the game, and it'll probably be in Bangladesh. We're trying to work with the FAO to do a big study in Bangladesh to ban OPs and carbamates from clustered areas and seeing what effect that has on agricultural yield, agricultural costs, and healthcare costs and suicide. We'll be able to come up with a holistic number that says, if you ban OPs and carbamates, it will cost you $10 per life saved, whatever. You come up with that. So hopefully we'll do that over the next few years. It's a bit of a pipe dream, but the discussions are happening. And we proved you could do it. Yes, come on. So what we try and do, our group, is work to reduce global suicide by 10 to 20% over 10 years. And that's about 150,000 deaths per year. So I can move down to my 3 or 4 deaths for the rest of my life if we move towards this. We work with doing clinical studies and randomized controlled trials, mostly in Sri Lanka, but we also work elsewhere in Asia, mostly in Bangladesh now. And that's informed by some very small animal work and basic science we do, mostly here in Edinburgh. We also do big public health intervention trials to try and add information in that. But fundamentally, the way you're going to make a difference is by working with government, WHO, industry to change policy. And in Sri Lanka, that's extremely easy. We have a very, very good relationship with the provincial and national ministries of health and agriculture, which allows us to provide information for them to make their decisions. That's a rare situation to be in. It's actually a really fun place to work. Next slide. So have we had any effect? This is a WHO report on preventing violence. It was called Guns, Knives and Pesticides, Reducing Access to Lethal Means. Having worked in Paisley as a house officer, I knew a lot about guns and knives, which was that was my old habit. And then I moved to pesticides when I became an SHO. And next slide. This was about reducing access to pesticides. There was a little summary of it, and all 6 of those from our group. So we've actually managed to take the data from Sri Lanka and put it into world guidance, which has been very fortunate and very rewarding. Last slide. So clearly I work with lots of people. And we try to engage industry. It's not easy. It also takes a lot of time, and I don't really have that time or the resources to spend my time sitting down in Kevin Over's head office talking them through the data. So one day I'll get money and be able to employ someone to do that for me because I just don't have time. But there's a lot of people here in Edinburgh, especially with the large animal work. Costello and Elspeth working on the 2 models with Richard, Gemma keeping us together. And then everything going on in Sri Lanka. The Sri Lankan work here on safe storage. And of course, Adrian keeping me up. Thank you very much indeed.